Dr. Hugh Foy, who will be up to the podium next, is a professor of surgery at UW School of Medicine. He's the director of the Surgical Specialties Clinic at Harborview Medical Center and practices general and trauma surgery as well as surgical critical care. He's a faculty member in the UW School of Medicine Colleges system and heads the Wind River College. He obtained his medical degree from the University of Nebraska, completed his residency here at the University of Washington, a fellowship in burn surgery and critical care at Harborview Medical Center. Dr. Foy's clinical interests include trauma, surgical infections, gastrointestinal surgery, management and reconstruction of the intestinal tract, complex wounds and abdominal wall hernias, and he's been awarded the Margaret Anderson Award for his help and support of UW medical students as a mentor. With that, I will conclude my remarks and turn it over to Dr. Foy, and I just want to tell you, have fun. This is going to be a great series of presentations, and thank you again for your attendance.
Welcome, everyone. Let's take a quick straw poll here. How many people in the audience are undergraduates who are actually seriously considering this endeavor, medical school? Show of hands. Oh my gosh. Good. That's fantastic. I'll just say from the onset, you always want to start on a positive note. Because you do hear a lot of things about, oh, the practice of medicine is not what it was. Nothing is, actually. It surely changed a lot in the last 30 years since I started my residence here in Seattle, and a little over that before I went to medical school, and much longer than that before I decided. But I'll really have to say I have no regrets. Obviously, you know, I've been lucky enough to survive this environment, but I really do feel at the depth of my heart that every morning I get up, I'm excited. I can't wait for the day to start and all the challenges and excitement that the day will bring. And I lead a fairly exciting and oftentimes unpredictable life at Harborview as a surgeon in one of the 5 largest trauma centers in the United States. So I had to learn very early to embrace chaos. Let's start here with the first slide. And a bit of a geography lesson. This is obviously a picture of the same mountain from 2 very different perspectives. In the top left, it's on the start of a several-day hike into the wilderness. And you can see my 2 sons there. Still look pretty chipper. They're not worn out yet. But that mountain in the background is obscured by another mountain. They've never been there. They don't quite know what they're in for. And anything can happen. And that's a bit like the journey that many of you perhaps are starting out now. You're in that strange environment where, you, as our former Secretary of Defense says, you don't know what you don't know. That kind of double negative of a lack of experience and true lack of knowledge. But for me, in my perspective, well, it's easy. From 20,000 or so feet flying over those mountains in the Cascades, I know exactly what that mountain is because I've seen it from many sides. So the perspective is very different. And what I'm going to try to do is lead you through that changing perspective that I've had over my career in medicine. To start, it's important that you understand that medical education, at least in the 3rd, 4th years and beyond, is much different than the education that most of us receive from the time we let go of our mother's hand and walk into kindergarten. That type of education is very passive, right? It's also known as the education of children or pedagogical education. You sit quietly in your chair with your hands folded, you listen to the teacher talk, you might take some notes later on, and then you regurgitate it on a test. So it's a relatively passive phenomenon in terms, at least, the interaction in the classroom. In contrast, medical education beyond that third year, and the second year is really a transition, is really adult education, which is quite different, or andragogy, as people have called it. There, the learner is inherently active. It's really on-the-job training. It's an apprenticeship, and that was something that was very early appreciated, as we'll see in the history slides to follow. It's experience-oriented. You learn by seeing patients, by taking care of them in a real-life clinical environment. And nothing reinforces learning like a real experience, or it's also known as contextual education, where you remember things so well once you've actually seen it. I learned in my third year on my medicine clerkship the pathophysiology, or what goes wrong when a patient has liver failure and their stomach blows up with horrible accumulation of fluid or ascites. And I learned that so well because I had one of my very first patients, I'll never forget him, who had intractable ascites and a belly full of fluid. So it was so large and the pressure was so tight he could barely breathe. It's also important that it's self-directed, so that in terms of setting your goals and objectives and how you're going to do it, it's really up to you. What you get out of an educational experience is mostly dependent on how much work and effort you put into it. You have to be focused. In the military, they call that focus situational awareness. And I was reviewing some literature the other day about teaching technical skills in the operating room, and they kept referring back to the military experience where they teach fighter pilots is probably the most fulminant example, if you will. It's basically paying attention. Or if clueless is not paying attention, maybe this is clueful. But really being in the moment and really paying attention and not just looking at something, but truly seeing it and being totally aware of the environment and the patient situation around you. The other thing is, it's been stated that the currency in this educational environment is feedback. You really can't learn unless you've got experienced people alongside with you critiquing and helping you make mid-course corrections. Feedback, it's like riding a bike. You can't get out there and go give it a try and fall over and go 2 weeks later and give it another try. You've got to have somebody helping you there, pushing the bike, getting you moving, telling you okay, and patting you on the back and wiping your scraped knee off. You need that feedback all the time so that you can appreciate, so that you're not just looking, but you know what you saw. And sometimes it takes an experienced eye to do that. Just in those slides there, you can see whether it's in the end of the year course that we give to the fourth year students there who are learning how to put in a life-saving chest tube in a patient with a collapsed lung. And that's in a rubber latex dummy in a simulation. Or it's in the operating room at the bottom slide there, where there are people all along the hierarchy of clinical education, from a medical student in their third year. There may even be a first-year student there doing what we call a preceptorship, just observing, to the guy standing on the stool who's an experienced, fully trained surgeon from Australia who's come to our trauma center to learn what we're doing. So that's real-time online education. And unlike many of the military analogies, and if you read anything about technical education, I'll talk about this, we don't have time to put you in a simulator for a long time. We oftentimes don't have time to sit down and debrief you all the time. In fact, in clinical education, much of the time, we are teaching people on the go, on the fly, under live fire of a sick or perhaps dying patient. So it's a very different phenomenon than that first 20 years of your education. This is just an outline. You know, after the Civil War, medical schools were what they call proprietary medical schools. It was, you know, you pay me money and I'll teach you some stuff and then we'll stamp your forehead with MD and send you out the door. There were no standards. There was no established curriculum. They were not affiliated with any academic centers of higher learning. Things started to change towards the end of the century, and the advent of the academic medical centers came onto the scene. And there was a sentinel report in 1910 by a guy named Flexner that really was a call for reform. And then the 1910 through 1940s was a time of explosion of scientific research as medical centers started to affiliate themselves with universities. In the 50s to 70s, there was a continued research emphasis, and there was just an explosion. Getting research grants was somewhat easier than it is now, and the explosion in knowledge was just amazing. At the same time, there was a reorganization of graduate medical education, or the training and education of people in residencies, which is that time after medical school where you learn how to be a pediatrician, a surgeon, an internist, a family physician, or whatever. And at that same time, those residencies started to organize themselves and set their own standards of accreditation. One of the landmark institutions, and really the birthplace of clinical education, is the Johns Hopkins University in Baltimore. And in 1893, they decided that they were going to establish this large, extremely well-equipped, up-to-date hospital that was focused on educating the physicians of the future. And they were really prescient. They really looked to the future before Flexner's report came out. And how many of you have ever been to Hopkins and been to the rotunda? If you ever go to Baltimore, did you go and touch the foot of the statue? Yeah? You go and it wasn't really a religious institution, but in the rotunda there's a very beautiful 20-foot tall marble statue of Christ. And it's good luck to go by and rub his foot. And you'll see the foot's almost worn down. But Hopkins was an amazing place. And there was several people that are famous from Hopkins. One was William Osler, who's probably considered to be the father of medical education. He's a brilliant man, but his main focus was on teaching students and residents at the bedside. And Osler was an amazing man. And there was a surgeon there, William Halsted, who at that same period of time went over to Europe, because before this time, everybody would go to Europe. Any physician worth their salt in the United States of America had to go to Europe and study, usually in Germany or Holland or France, because the Europeans were far ahead of us, you know, with Pasteur and all of these, Leeuwenhoek and all of these people that made these great discoveries in microbiology and microscopy, etc. Well, things started to switch. Halsted went to Vienna and studied under a guy named Theodor Billroth. And Billroth had this monastic system of regimented, almost militaristic residency training program where the residents lived in the hospital. They were never even excused for leaving. But it was a very strict, almost paramilitary hierarchy and chain of command. And Halsted came back to Johns Hopkins and established the first organized surgical training program in the country. And every surgeon, at least my teachers, could all trace their lineage professionally back to Halsted. It's kind of a professional hobby. But Hopkins was really where things got rolling. And then in 1910, Abraham Flexner issued this report, which was the medical education in the United States and Canada. And it was a scathing indictment of the situation outside of probably Hopkins, of how backward, disorganized, and unprofessional these proprietary medical schools were. And Flexner was said to be an acerbic, biting, very almost brutal critic, but he could turn on a dime and also be phenomenally charming. But the Flexner report you'll hear referred to again and again and again, and it said that you've got to have an organized curriculum in medical schools, They should be affiliated with a major university in an academic environment where it fostered research as a major portion of the academic mission. So the Flexner report really set things and the world of medical education on its ear. It was fortunate about that same time there was another major reformer in the total education process, John Dewey, and one of the great spin-offs of the Flexner report and his call for an improvement in medical education. It's kind of like the space program. You do the space program, everybody says, why do you want to send people to the moons? Well, all of the technological development that was fostered by that emphasis and that funding has spilled into much of the rest of our lives. And the same was true with how the Flexner report and the call to arms to reorganize medical education spilled almost retrograde back into an improvement in education at the grade school and high school and college level as well. So Dewey, who was a very progressive educator, these two people really took off and the movement soared forward. In the 20s, there was this enormous emphasis on research. And every academic physician was expected to perform research either in the lab or clinical research in order to investigate, with all of these new tools that were being developed around the world, the mechanisms of disease. See, before the Civil War, there wasn't really a lot you could do if you knew about disease because there wasn't very many effective treatments. At the turn of the century, there are many effective treatments. New drugs, I mean, you think aspirin, big deal, aspirin. Aspirin is huge, and any parent in the audience, right, knows that what a single dose of Tylenol or acetaminophen to break a fever, it'll take a child that looks like they're on their deathbed and make them look normal in 20 minutes. So just a simple drug like aspirin to break a fever was a major breakthrough. But then with Halsted and a more scientific approach to surgical treatment and the development of general anesthesia, all of those things in research really started to snowball. There's a great movie about the heyday of this time that Something the Lord made, about a man named Alfred Blaylock, played in the movie by Alan Rickman. And the guy who was actually the hero of the movie, Vivien Thomas, was a janitor in Blaylock's lab who actually turned out to be very bright, very adept, and very skilled. He used to make parquet floors for his father. Before the Depression and when their construction business went under, Vivien Thomas then turned out to be the guy to teach all of Blaylock's residents and trainees, most of whom went on to be the major developers of open heart surgery. Vivien Thomas was the guy who would teach him how to do this anastomosis of this Blaylock-Taussig shunt, which was a revolutionary treatment for babies with congenital heart disease, this thing called tetralogy of Fallot, where their heart is misshapen. And these guys developed this shunt just simply making a communication between their pulmonary arteries and their other main arteries that supply the rest of the body. Truly amazing. I'd really recommend the film. It is a great film. You should put that on your list in your queue, as my sons would say. And that there depicted in the background is an actual copy of Blaylock's operative report of the first Blaylock-Taussig shunt. Well, in the 50s and 70s, there was an increased emphasis again on research. Research. It really became preeminent in medicine. There was also the development of innumerable specialties. And this is, as we say, a very busy slide, and I don't expect you to read it from your seats, but it's just there to illustrate the fact that this specialization of medicine just exploded. And under each of the headings on the left are up to 20 or more subheadings of subspecialties. So in internal medicine, here you got a whole list of things. In pathology even, there's a whole list, pediatrics, etc. There was also an organization of residency accreditation, as I mentioned before, and there was a tripartite organization founded, the Accreditation Council for Graduate Medical Education, between the American Medical Association, the American Hospital Association, and the American Board of Medical Specialties. And they all got together and they said, okay, we got to get a handle on this residency training thing, and they developed what they call RRCs, or residency review committees. And each specialty goes out and makes sure that a program in whatever training hospital around the country is doing the right thing. Well, it became apparent that academic medicine was really a three-legged stool, and it's thought classically that those three legs are patient care, obviously. First priority is take good care of the patient. Secondly, as Osler and Halstead and all those people and Flexner said, you've got to teach people how to do this. You can't just merely sit them in a room and teach them from a book. And as Flexner wrote, the art of medicine can be learned, but I'm not sure you can teach it. So you can sit and talk and talk and talk and talk, but that doesn't guarantee you're going to have a trained physician that really knows what to do. So this idea of interactive, experience-oriented adult education in the hospitals and in the clinics was really an important part of that three-legged stool. And of course, research. Well, there's been this continuous struggle for the balance between those three stools as time went on. Research became preeminent, and in times it's actually overshadowed many of the other two. Well, we'll jump then to what we'll call the recent history of medical education through the 60s and 70s. And the 60s and 70s, as many of the rest of us in here with our bifocals and maybe a couple of gray hairs will remember, were phenomenally tumultuous times, as they were in medical education as well. There became then in the 80s a more market-based approach to clinical care. There were some incredible reform movements that were instigated and employed within the system of medical education, and as well as some government regulations and changes like the Balanced Budget Act that made a huge impact on graduate medical education. Fortunately, there was a renewed emphasis on the teaching portion as we got a little bit perhaps off track and forgot that third wobbly leg of the stool, and then finally some work hours restrictions. Well, one of the landmark events in modern medical education history is the signing of the Medicare Act in 1965. And here you can see Lyndon Johnson bent over the desk signing the paper with his wife behind him. And this was signed at the Truman Museum in Independence, Missouri. And there's Harry Truman and Bess Truman sitting there with Lyndon Baines Johnson and Lady Bird. The deal that was cut in 1964 with Academic Medical Center with the federal government was, look, you sign on to this guaranteed health insurance for the elderly in this country, and the federal government will give hospitals money to pay for resident education. And it was a lot of money, and it still is a lot of money, but it's one of the untold stories in the whole picture, and you'll see later why this is very important. So really, residents in the hospitals are paid under the Medicare budget. Now, how many of you here remember 1968? Got a lot of press the last year, right? I don't know about you, but you know, I was only 13 years old, but I wasn't sure I would ever see my graduation from college. I mean, it was a tumultuous time. And assassinations, like you can see in the photo on the left of Martin Luther King, Robert Kennedy, John Kennedy. There was the riots in Watts as depicted by that soldier sitting there in our own streets in one of our major cities. Our cities were in flames, whether it was East LA and Watts or Philadelphia or even in my own home state, Omaha, Nebraska. It was a very frightening times. And then superimposed on that was the Vietnam War, where there was an enormous resistance to the war, to the draft, and then to some of the policies that ensued. One of the Sentinel publications was there was also turmoil among residents at that same time. And the book at the bottom right there is by Fitzhugh Mullen, who then, after he was part of a very radical experiment in the Lincoln Hospital in the Bronx, went on to be the Assistant Surgeon General of the United States and run the National Health Service Corps. But it was an extremely tumultuous time, and at that time one could arguably say and make the point that health care of the urban poor, and we remember what it was like to be on a subway in New York City there, or to be in Philly, or be in East LA. These were dangerous times. But the care of the urban poor rode on the back of residency training programs. Or if you really wanted to take it a step further, rode on the back of a federally funded industry of indentured servitude. And the residents rose up. The Committee of Interns and Residents in New York City finally said, we've had enough. We've had enough of every other night on call. Every other night on call, 40 on, 8 off. 40 hours working steady, 8 hours off, come back the next morning, do it again. And that's what it was like in many training programs, and even in 1978, 79 in our own city. Brutal, brutal working conditions. Well, finally, there was a sentinel event in New York City, and a young woman named Libby Zion died one night due to probably a medication error by a tired resident. Just so happened that her father was a very prominent lawyer in New York City, and he wouldn't just lay down and take it for nothing. And it initiated the Bell Commission in New York State, who finally then imposed strict hours requirements on the residents in New York State. And the business of medical education went crazy. What do you mean they can only work 80 hours a week? There wasn't very good monitoring either, and to some it was known as sleeping for dollars when as it was known. But people worked exceedingly hard in residency training programs during that part. And it was just it was thought to be necessary and part of the process. Well, in the 90s and 2000, there was a renewed emphasis on education, and I'm probably living proof to that effect, as I was one of the first people to be promoted on what's so-called clinician teacher track here in our own university. But as research faculty were really pressed for time. There was less and less time to teach students and residents on the ward. There was increased pressure from this market-based approach that was really started in the 80s under the Reagan administration to generate clinical dollars, because as things changed and a lot of funding mechanisms for clinical care, like diagnostic-related gratuities and a whole variety of things changed, people had to work harder to make clinical dollars to make sure their hospitals and universities could stay open. And that trend has continued to this very day. But there was also establishment of the concept of a medical educator as a more professional educator. And a variety of different groups grew up. The Association for Surgical Education in my own field, the Association of Program Directors in Surgery, you know, these Simon Legree guys cracking the whip even got together and said, how can we do this better? As well as the Society of General and Internal Medicine and a whole host of others. In 2000, the University of Washington went through a curriculum review, and they said, we really need to do this a little bit differently, and they started the Colleges program, which I'm a very proud member of now, where we split our student body up into these 5 virtual colleges to provide for a more intimate relationship with experienced teachers, to give them career mentorship as well as a regular clinical education process that occurs every morning, 1 morning a week, where there's just 6 students and 1 faculty member. So that third wobbly leg of that 3-legged stool of academic medicine was shored up. At the same time, there was a lot of change in healthcare, and the Clinton health plan in the mid-90s, or the so-called managed competition, was this incredible flare that went up that almost paralyzed the industry. It didn't pass, it didn't play out, but it caused enough shakeup in the industry that it almost paralyzed things for about 6 months, and no one was quite sure what to do. Part of our UW Medicine network was a response to this fact that we knew as a tertiary referral hospital, we had to have a broad network of primary care physicians to feed into us. So billions and billions of dollars were spent. The thing never really came to fruition, and perhaps the people who had the most capital to expend were the large insurance companies, and they ran with it. They ran with the ball all the way to the goalpost in terms of for-profit HMOs, or health maintenance organizations. We have one of the oldest health maintenance organizations right here in Seattle, Group Health and others, that are run by a board of their patients, and mostly not for profit. But the for-profit HMOs, where you get paid more for doing less for the patient, really took off, and actually billions of dollars went up in smoke. And in 1997, Dr. Phil Gramm, and the GrammRudman Bill was an attempt by the administration to get control of medical spending. And they said, okay, the gravy train of you guys getting the money for all these residents is coming, if not a halt, is going to slow way down. That you cannot have any more federally funded residency positions than you have right now in 1997, okay? How many of you know the 7-10 rule of investment? That's a bad word these days. Anybody know the 7-10 rule? It's one of these interesting numerologic phenomenon. If you're making 7%, you'll double your money in 10 years. If you're making 10% on your investment, you'll double it in 7 years. Well, do the math in relationship to the GrammRudman Bill. And now, 12 years ago, they said that's enough residents, okay? I can guarantee you that care of poor people and uninsured people in our safety net hospitals in the inner city have not shrunk. And in fact, they've almost doubled in many institutions. At the same time, where our workforce has been curtailed in terms of their absolute numbers, and that money, that Medicare pass-through in 1990 was already 14% of the operating budget of teaching hospitals. So in 2003, finally, this ACGME, the Accreditation Council for Graduate Medical Education, said, okay. And they told John Conyers in the House of Representatives, don't pass the bill, don't pass the bill. We'll do it, promise. Trust me, I'm a doctor, you know, because they were going to pass federal legislation, so the ACGME came down and said, boom, 80 hours, that's it. No more than 80 hours, okay? What that did in inner city teaching hospitals, it cut your effective workforce by 25 to 30%, boom, overnight, okay? You do the math of how much money you get for a resident, how much it costs to, say, hire a PA, a physician's assistant, or a nurse practitioner. Math doesn't work very well at all. So there was really a problem, and so we've been faced with these contingencies in medical education, particularly graduate medical education, ever since, and a whole host of spin-off problems. Well, enough of the happy stuff. We're going to talk a little bit about how do you get into medical school. This is a picture of my 6 students when they got their white coats. It's the clinical transition ceremony at the end of their first 2 years. Well, how do you get in? Well, first you got to go to college, right? You got to go to get your pre-medical degree, Bachelor of Arts, Bachelor of Science. In both of those things, you got to fulfill your pre-med requirements, as many of you know. Then you have to take the test. You got to take the MCAT, the Medical College Admission Test, and you got to do all these things on that strict timeline. You got to take the MCAT by the fall prior to your expected entry into medical school. Then you got to fill out these great big long form like the ERIS application at the bottom. You've got to include transcripts of all your grades, your personal statement, that you've got to write a why I want to do this, recommendation letters. Then you're invited for an interview, hopefully, and in the late winter, early spring, everybody's just kind of sitting on pins and needles, aren't they, waiting for that letter to get interviewed to go. The acceptance comes in spring, and entry is usually in late summer and fall for your first year. And those first 2 years are what we call basic sciences. Basically, you're in a lecture hall like this, you're listening to lectures for more than 70% of the time, you're taking notes, and you're taking tests. So for many people, particularly those who have been in their second career, this is kind of an educational regression that is not really, doesn't really sit well with many of them. But as I look and see people in our so-called physician extenders or nurse practitioners who have an enormous experience, or physician's assistants, I really appreciate the depth of those 2 years and all that medical knowledge. It's really a phenomenal foundation for the second 2 years when you go out and take care of patients. There are also small group discussions, so-called problem-based learning sessions, which are less structured, where you're given a clinical problem that you've got to go in your small group and figure out, as well as classic anatomy lab where you work with cadavers, look at histology slides under the microscopes, etc. The third and fourth years, again, is when you make that jump, that quantum leap from pedagogical to andragogical education. And this is really adult education. You put on that white coat, you go out on the wards, you herd around and follow around a team of residents in training, attending physicians like myself, and you have to do a certain number of required clerkships. The big 6 are those in yellow there, in the fundamental disciplines of medicine for either 6 to 12 weeks. And then you've got a variety of other, including rehab medicine and others that you've got to fulfill in the rest of your third and then your fourth year. So like Brian there, you've really got a front row seat on the action. And there they are, scrubbed on a case with us, getting ready for the operation. And in fact, we teach them how to start the suture and a variety of different things. Typical day for a third or fourth year students, you're usually starting by 6 a.m. You're at the hospital. Rounds usually start at 7, sometimes a little earlier. There's often morning conferences where we sit down, present last night's admissions or new patients, go over them with your supervisors. There's more often than not a noon clinical conference, a little bit of time in the afternoon to get your ward work done, take out stitches, hunt down the x-rays, etc. You have to write a note in the chart, whether it's with a pen or now with a keyboard, right? Hence the term the clinical clerk or the clerkship. And that was the original idea, that the student was the scribe that recorded the patient's progress every day. And at about 6 p.m., now with our hours requirements, you check out, tell the people coming on board what's going on. Well, there's a ward hierarchy, as you all know. I don't watch these shows much, but you know, Grey's Anatomy. How many of you watch Grey's Anatomy? I saw it once. It's sort of like that, not really. How about ER? ER, some more people. Nothing happens that fast, and I can tell you, at least in our ER at Harborview, people are nicer, okay? Both the doctors and the patients. So third-year students on the service, there's oftentimes a fourth-year student or a sub-intern. Then the first year of residency is really your internship. The second year, the third-year person's kind of the service manager, and in specialties like surgery that require more than 3 years, there are senior residents, and even people into their 6th and 7th year of training as well when they do what we call fellowships, or area of added emphasis in a certain sub-subspecialty, if you will. But each team is led by an attending physician who's a fully trained and most often board-certified person in that particular field, who's also legally responsible for this care in this really system of what we call graduated responsibility. So we give people an opportunity to see our patients, to work on them, and they help us with the more mundane chores. And as you work up that hierarchy, you're given more and more responsibility as you've proven yourself knowledgeable and able to sort things out and to take care of the patient. We encourage independent thought, but not the independent action, particularly if it's something that's critical. You know, there really needs to be very efficient and timely communication up and down that chain of command, just like the military. I mean, the situations are pretty similar. I mean, we got people that can die out here, so we've got to make sure that our communication is pretty clear and that the transmission of information is as efficient as possible. And for the most part, the electronic medical record helps us achieve that for the most part. It requires a two-way street of both judgment and trust in that relationship. And again, it's in a situation where life and death is really oftentimes important. There's a proscribed manner of communication. And this is just the handout we give our students of the oral case presentation. And you're going to see an example of that in the next hour, of when somebody's on the ward, how a student presents. Whether it takes the full 7 minutes or it takes 30 seconds, the way and the manner and the order that it's done is always the same, okay? Even though you might just hit the major highlights, that order is very prescribed, as is the history and physical, which there's an example here, and you can't see the details. But this is a submitted electronic word process document. and the history and physical, which is an intake evaluation that's based on an interview of a patient, a collation, a physical examination, a collation of information and data from maybe the paramedics, maybe a family member, if it's a pediatrics patient, the lab tests, the x-rays, etc. And it's all collated into this very rigid document format so that the clinical information is very efficiently transmitted. And even the verbiage, not just the order, but the verbiage and the exact words in a normal exam is always spoken and always written the same way to try and minimize the amount of error. Well, the oral case presentation, as I mentioned, is supposed to be less than or equal to 7 minutes. It's shorter if necessary. It's always in that same format, and there's standard terminology. And you can just see here's an example of this is a couple years ago when Ann, who's our resident, we were making rounds seeing patients, and I was teaching them about the physical exam. We then do some clinical problem solvings. Well, how do you sort this out? How do you figure out what the problem really is? How do you take the first line of that H&P, the patient's chief complaint? When we ask you when you come to the doctor, what brings you to see us today? And you go, my belly hurts. How do you go from my belly hurts to a diagnosis, which is acute appendicitis? It's clinical problem solving, and it's just a manner of how we sort this information out. Sometimes we use inductive logic. We use the probabilities based on the age of the patient, their sex, their prior medical history, and all of these different features to then generate what we call a differential diagnosis. Or this is the list of possibilities for this patient's diagnosis based on what we know, and they're ordered in the order of likelihood that we think is most likely to be the case. So then you develop a plan, and every plan has things you're going to do to get them better, therapeutics, some other things you need to figure it out, diagnostics, more tests, and always patient education. And I think it's exceedingly important to tell a patient what you think's going on and to have a more open forum and a two-way communication. And I think of anything, we fail in that regard as physicians, and one of the main emphasis of the college program, at least, is to teach people how to keep those lines of communication open better between the doctor and the patient, and then always the follow-up. There's another book, How Doctors Think, you might find interesting that's on your reading list that goes through that. Well, you've got to pick a residency. You've got to figure out what's the best fit. You then apply for that. You then get interviewed for residency, and that usually comes in January or December and January of your 4th year of school. And then you submit your rank of places you'd like to go as a 4th year student, and programs around the country submit their rank list of students they would like in rank order, and it all goes into a big computer, and it's like a solitaire game where you always play up, okay? And the student has the house advantage, and it's all played up until the Ides of March, and the results are published. You get in this big room, you get an envelope, and your fate is sealed for the next 3 to 5 years. Pretty remarkable and momentous day, and then you go and start your residency that depends, again, based on your specialty, how many years you're going to take to finish your residencies, anywhere to 3 to 5 in a surgical program or neurosurgical program where there's 2 years of required research training. That might be up to 7 years of training, where you're still an apprentice under the guise of attending physicians in this system of graduated responsibility. And here's 2 of my residents who are performing an exploratory laparotomy. And sometimes as the year moves on and I'm comfortable with what they can do, I may need to just look over their shoulder. But I make sure that it's done correctly every time. Well, what about the future? You can see in that graph, that white area, that there's a gap. There's a shortfall between the supply of physicians and, the shortfall is in the blue. That there is a gap in terms of the number of people we are giving an MD degree in this country and the number of residents that we're training. And even if we increase the number of people in medical schools by 30% tomorrow, the pipeline is up to 10 years long. So if you look at the demographic progression and projections, excuse me, of the baby boomers and our aging population and the number of people we're training, the future looks to be very challenging, as was a theme in a little speech we heard a couple of weeks ago. There's not only a growing aging population, there's increasing student debt, there's less people who choose as a result to be primary care physicians for a variety of reasons, and one of them is in fact that when they walk out of the door they're in so much debt that they would really rather be a specialist that does a bunch of procedures in our current reimbursement environment than perhaps somebody who's just doing the heavy lifting and legwork out there, seeing patients every day, day in, day out, as a family practitioner or a general internist. There's also threatened federal support. And so really we're moving towards a sustainable future. Parenthetically, I'll just remember the people that brought us a Balanced Budget Act in 1997 were also the people who deregulated the banks. They're also the people who wanted to give our Social Security treasure chest to Wall Street. So, you know, as you read these things and put them into perspective, what we really need to do is move towards a sustainable future. And it's going to take some heavy lifting and some hard work and some major changes in policy in order to increase the number of all healthcare providers. How much longer can we just hire trained nurses from the Philippines? How much longer can we continue to suck 5,000 to 8,000 physicians out of the developing world, which we do every year to fill empty residency spots, which is really, if you look at it, I mean, how socially irresponsible is that? In terms of, you know, everybody talks about we got to do what's right for our country. Well, maybe we should start thinking about doing what's right for everyone around the world. I mean, we're going to build a whole new department about global health, but at the same time, we let 6,000, 7,000 physicians trained from the rest of the world in here just so we can fill that federally subsidized industry that is, you know, takes care of our inner city poor. I don't know. I won't make any judgments. You do the math, okay? And maybe we need to give bounties for people to go into primary care, for physicians not to go into early retirement. You know, the collapse of the banking industry maybe have a bigger impact than we thought, because all these guys sitting on their big 401ks are going, oh, geez, I don't know if I want to retire at 57. You know, maybe we're going to have to work a little bit longer as physicians. And maybe we need to rethink this market-based approach, which we do a lot of things in medicine based on, well, how can we generate the revenue? And we do a lot of things that I could just tell you I think are not very bright and they're not sustainable. Just like a noted Nobel laureate Paul Krugman said about 4 years ago, the current economic situation is not sustainable. People ask me how long it'll last. Well, I really don't know. I don't have a crystal ball, but I did a few calculations. If I had to guess, I'd say it's about March 5th, 2008. I think a lot of the things we do in the next economy that is threatened is the medical economy. And I think unless we make some changes and make them pretty soon, it may be the next one to topple. So I think the solution is really a shared solution. All right, let's go. Let's go. Come on, we got to hustle. Let's make some rounds. Lee, you're on the service again?
Yep.
Okay, well. All right, let's hear the story. Ann, welcome back.
Thanks.
Yeah. How was pathology?
Excellent.
Yeah, good.
Yeah.
All right. Go ahead, Kathy. Let's hear about this patient.
All right, so this is also a Miss Lee. She's a 17-year-old woman that came in complaining of abdominal pain. So she was well until about 24 hours ago when she began experiencing lower right quadrant abdominal pain. The pain doesn't radiate, doesn't go anywhere. Onset was insidious, became worse. She hasn't been hungry at all. She endorses fever, but she doesn't have chills or sweats. She doesn't have any pain around her umbilical area. She last ate about 24 hours ago when the pain began. She is still having flatus, but has not had any nausea, vomiting, constipation, or diarrhea. She doesn't have any problems with urination. She last had her menstrual period about 2 weeks ago, and she denies any sexual activity in ever, and she has no episodes of abdominal pain like this. She doesn't have any other medical problems. She's never had surgery before. She does not take any medications, and she's not allergic to any medication. She doesn't have any significant family history. They don't have any abdominal problems, no cancers, no cardiac issues, no problems with anesthesia. Social history, she's originally from Hong Kong. She speaks Cantonese only, but her sister is here. Her parents are still in Hong Kong, but she lives with her sister, and she's able to take care of her. She does not smoke, drink alcohol, or use any other illicit drugs. Review of systems was significant as stated above and otherwise negative. Her vital signs, she's afebrile right now at 36.8. Blood pressure was 107/68. Heart rate 72. Respiratory rate 18. She was satting 100% on room air. She's a really slim young woman lying really still in bed. Doesn't look like she's in any acute distress. Head, neck exam or without any notable findings. Her lungs were clear to auscultation and auscultation bilaterally. No wheezes, crackles, or rhonchi. She had a regular rate and rhythm in her heart, no murmurs, rubs, or gallops. Her abdominal
You can just tell me about her abdominal exam.
Okay.
If that other stuff's normal, just you can tell me.
So her abdominal exam, she had a non-distended abdomen. She didn't have any scars. She did have bowel sounds. She was soft, but she was very tender to percussion and palpation, especially in the right lower quadrant with maximal tenderness at McMurney's point. Pelvic and rectal exam were performed in the ER, so I didn't repeat them, and those were abnormal. Otherwise, exam was normal.
No chandelier sign. Didn't hurt lateral cervical motion. She didn't have a lot of tenderness.
I didn't do that.
Okay.
So.
But the ER, did you talk to the ER docs? What did they think?
Oh, it was lateral cervical tenderness. So they said no, no tenderness. Good. Yeah. So they did do imaging, and they saw a thickening at the base of the appendix, measuring 1 centimeter at the base to 4 millimeters at the tip.
The ultrasound or CT?
The ultrasound.
Ultrasound, okay.
And they didn't see any fat stranding, but she's very thin. She has no fluid collections, and they actually suggest a CT if clinical exam is not suggestive of appendicitis.
Do you think we need to do that?
I do not think we need to do that.
Okay. Go ahead.
Her labs, her Chem 7 was essentially normal. CBC was significant for a white count of 14.6, and her hematocrit was 39. Platelets were 197. So this is a 17-year-old woman with symptoms and signs and imaging consistent with acute appendicitis. The differential also includes ovarian torsion, Meckel's diverticulum, Crohn's disease, atopic pregnancy, but those things are less likely, especially with her history and onset of symptoms.
So what's your impression? Overall, I mean, she's got a differential, but what do you think her diagnosis is?
I think she's got acute appendicitis.
Okay.
So I think that we need to start preoperative antibiotics. I think that we should make sure that she doesn't eat anything before we go to the operating room, and I think she needs an open appendectomy.
Okay. Ann, did you see her?
No, I haven't seen her yet.
Okay. Did the other students see her? Do you know?
The
other medical students?
Yes, they have.
Yeah, good, great. So what do you think the most sensitive sign of peritonitis is?
I think the most sensitive sign is tenderness to percussion.
Yeah, just light percussion. So when you tapped over there, over McBurney's point, over appendix,
she shoved me away and pushed me.
Yeah,
out
so
of
it
the
really
way.
hurt her a lot. Yeah. You speak Cantonese?
I do.
Yeah? Good. Sure.
That's Mandarin.
Good. And do you have any questions?
Yeah, I was just curious if you had tried any other physical exam findings that might be pertinent for her case, any rebound tenderness that you'd found?
You know, I tried the leg raise, and that was negative, and I don't remember what that was called, so I have to go look that up later.
So do you remember any of those? Any of the other adjunctive physical diagnostic maneuvers you can do, the appendicitis, that help you figure out where the appendix is? Is it anterior? Is it retrocecal?
I don't remember all those maneuvers. I do remember that if you do some sort of leg raise that you can elicit pain, but I think she was so upset with me after I had percussed that she didn't really want me near her anyway, so right.
So if you've got a retrocecal appendix and the appendix is sitting behind the cecum in the retroperitoneum, and there's a muscle right there underneath it, right? Mm-hmm. You remember what that muscle is?
The psoas muscle.
Psoas muscle? What's the psoas muscle do?
it pulls your hip up.
Yeah, flexes a hip flexor, right? So if you stretch that muscle backwards or extend her at the hip and cause tension on the psoas muscle, sometimes that can be a sign or known as a psoas sign. You know, lay them on their side and stretch their leg, they'll really hurt. Because sometimes a retrocecal appendix, because it's not anterior, will do that. Okay? The presentation is not as classic as this, and it can be delayed, and it can be ruptured and abscessed back there.
Oh, wow.
And do you have any other questions?
Yeah, I was just curious. I know that you started preoperative antibiotics, which I think is a great management strategy. Your patient is going to surgery, and we noticed kind of a trend in her vital signs that she was getting a little bit more tachycardic, her blood pressures are dropping. What kind of management tactics would you do in that situation to help out your patient who's going to the OR?
Thank you for reminding me. I think we should definitely start some IV fluids, maybe some lactated ringers.
All right, particularly in an elderly patient, right, with vascular disease. You don't want them to have an anesthetic drop their pressure when their blood volume, you know, they're hypovolemic, because they'll crash, right? Okay, very good. So do this. Anne's in a hurry. She's running for another emergency. You got 30 seconds to get your point across. Okay, you're on the spot now. Can you handle that?
Sure.
Okay, 30
All
seconds.
right.
Tell her.
Hey, Anne, I have a patient. She's 17 years old. A woman came in with abdominal pain. She has been having pain in her right lower quadrant, no periumbilical pain, hasn't been eating, has flatus. Physical exam, her vital signs are actually normal right now. I can give you those numbers when you have a moment. And exam with significant force. A soft but tender belly. Imaging shows shows an inflamed appendix, so I think she has acute appendicitis.
Perfect. Very good. Excellent. So you can see whether it takes 7 minutes or 30 seconds, she hits the same highlights. What the patient complained of, what the history was, what her findings on exam were, what she thought she had as a diagnosis, and what we need to do. And really, when we document in the chart, so-called SOAP note, S for subjective, the story, O, objective, the things we find out that are irrefutable data, whether it's the vital signs, the physical exam, the lab tests. A, assessment, that's what you think what's going on. And P, the plan. So we break it down into those 4 essential items, regardless of how robust you fill in the blanks. So that's how we do things. We're making rounds, whether it's formal presentation again, or whether it's boom on the fly. Thanks a lot, Anne and Kathy. Appreciate it very much.